Have everyone get in. All right, well, we'll get started and go through our introductions before we get into the webinar. Thank you so much for joining us today. This is the first session in our new series, Unpacking Bedside Bioethics. This is a series in partnership with the Center for Bioethics and mHealth Fairview Ethics Service to bring kind of foundational ethics issues and ethics knowledge to clinicians that have real kind of bedside practical implications that will help you in everyday practice. So my name is Jaime Konerman-Sease. I am a faculty member. I'll introduce myself a little bit later, but first I want to thank Kayleen and Andrea and my colleagues at the center for helping get this series going. As I said, this is our first session. There'll be 3 more, so it's a total of 4, and more information about the other sessions will come out throughout the year once those are finalized and dates have been set. So first, I want to mention that the Center for Bioethics is, if any of you here are students, the Center for Bioethics has some upcoming courses for next year. Contact the email at the bottom of the screen if you're interested in these courses. From what I know, they're graduate level and open to med students as well, and perhaps some undergraduates can also take these courses. So if you're interested, contact the center to learn more about that. I also want to mention our ethics consultation service for mHealth Fairview. If you have an ethics question or want to speak to someone about an ethics concern, we have a 24/7 service. You can either place a consult in Epic or you can contact us via pager. This is our pager number, and we will get back to you as soon as we can, usually within an hour. Okay, so I'll introduce myself. My name is Jaime Konerman-Sease. I am a faculty member for the Center for Bioethics and an ethics consultant for mHealth Fairview. I have a PhD in healthcare ethics and theology, and I'm going to be presenting today on decision-making capacity, myths and misconceptions. You can contact me by email. That's probably the best way to get a hold of me if you have further follow-up questions after this presentation. I do have a Twitter. I don't really go on it that much, but I am there. So if that's a thing that you like to do, that's there for you. Okay, I do not have any financial relationships to disclose for this presentation. I will not discuss any off-label use or investigational use in this presentation. And before we begin into this thing, a few housekeeping things to mention. Use the Q&A function if you have questions about the presentation. For me, I will be checking that Q&A. We'll respond sort of back and forth through the Q&A function. Reserve the chat if you have technical issues. Kayleen and Andrea are here to sort of help for any technical issues or any questions. So keep the chat reserved for that, and that will help us sort of make sure to understand which belongs where, and I'll make sure to keep my eye on the Q&A. Okay, I will check right now. Oh, yes, Karen, thanks for your question. There will be a recording. The recording will be a link through the Center for Bioethics website through the event page. So there will be a recording and it will be sent out and updated later today. And that we'll also mention that at the end of today's presentation. Okay, so demystifying decision-making capacity. Decision-making capacity, what is it? Well, it is a clinical assessment of a patient's ability to make a specific healthcare decision. There are specific criteria for decision-making capacity, and it's about evaluating specific clinical situations. So can this patient make a decision about this particular surgery or this particular intervention or this particular diagnostic procedure? Capacity requires specific criteria, and those criteria are 4 pieces. There's 4 pieces to those criteria. First, understanding, appreciation, reasoning, and expression of a choice. So understanding, so the patient has to be able to understand the particular medical situation, the prognosis, the nature of the recommended care and the alternatives, and the risks and benefits of each of these alternatives. That encompasses sort of an understanding. Does the patient have the ability to understand these things? Second is appreciation. Can the patient truly appreciate the effects of that choice and the nature of the information? Additionally, are the decisions that the patient is making consistent with their values and goals, those deeply held values and goals that patients have? Do they truly appreciate the effect that that choice will have? And is it consistent with their values and goals? The third thing is reasoning. Do patients, are they able to use reasoning to make their choice? Can they demonstrate that there's sort of a rationality, that there's a logic to the process that they're making their choice, right? Does their process of making a choice follow a rational pattern? And is it consistent with those goals and values that they have? So important in part of reasoning is are these decisions resulting from delusions? Delusions are not rational sort of patterns of behavior. And so delusions would indicate that a patient is not perhaps using reasoning to make a choice. And finally, expression of the choice. Can the patient actually make and communicate that choice? Communicate either verbally, through writing, through pointing at signs perhaps, but there must be an actual ability to express the choice that the patient wishes to make. So those are our criteria for decision-making capacity. And I know we jumped right in, but what we're going to do now that we sort of have a very gentle or basic overview of the criteria is we're going to explore some of the cases. Some cases to sort of understand what applying these criteria really mean. But before we dive into cases, I want to talk a little bit about the intention and theory behind the idea of decision-making capacity. So decision-making capacity, the intention behind it is to honor and respect patient autonomy. The reason we assess a patient's capacities to understand and respect their autonomy. Everyone we know has a right to autonomy to shape their lives in accordance with their deeply held values and beliefs. People also have the right to be free from unwanted bodily intrusion, including within the medical sphere, right, within medical care. So within the concept of autonomy, we have a commitment to liberty, independence, self-determination. These are values that our nation was founded on, and we believe they have a place in healthcare. So this is how these values work out in healthcare. So we are respecting people by honoring their autonomy. And we find that decision-making capacity is a piece of that autonomy, but we know that autonomy is not absolute. Autonomy does not have unlimited sort of range in decision-making. And there are several reasons why a person might not have autonomy. Autonomy depends on the ability to act intentionally and depends on the ability to act on information, to act free from intervention, and to act free from control of others. So decision-making capacity is sort of an expression of autonomy. It's a key aspect of autonomy. If someone has capacity to make a decision, their autonomy should be respected. If they do not have capacity to make a decision, we believe that acting in their best interest, which is the principle of beneficence in bioethics, it outweighs that right to autonomy. So patients who lack decision-making capacity should still be respected as persons, but how we respect them changes because we prioritize acting in their best interest or beneficence over autonomy or allowing them to act out of their own kind of behaviors and own interests. So there are many reasons why a patient might not be able to make specific healthcare decisions. So we're going to discuss the nuances of decision-making capacity today through a series of case studies. So these case studies will be interactive. I'll be asking for your feedback. Low stakes. There's nothing that you will get from being right or wrong from these quick questions, but it will be a little bit contrived. I'll be asking you to narrowly answer yes or no, when in fact we know that most cases of capacity and evaluating capacity and ethics in general is a gray area, right? It's muddy. It is not clear cut. So it'll be a little bit contrived. So just know that as we go through. There's really no stakes involved in this kind of assessment. So let's begin with our cases. So case one, a 23-year-old woman with schizophrenia is admitted to the mental health unit for psychosis. While admitted, she asked to take an oral contraceptive pill. The courts have ruled that this patient is incompetent and her mother serves as her legal guardian. Can this patient make her own medical decisions about contraception? So I'm going to start our first poll. And go ahead and fill out the poll. You'll have probably 15 seconds to do so. Ooh, lots of feedback, fantastic. All right, I am going to end the poll soon, so if you haven't, go ahead. All right, poll ended, shared results. All right, we have about a split, 50-50 split. Great, fantastic. Some people are saying yes, some people are saying no. Yeah, it's confusing. It could go. So let's get into it. So the answer that I have for this question is yes, she possibly can make her own decision if she can demonstrate that she understands and appreciates the natures and consequences of the health decision. And this is because capacity and competence, though related, are distinct things. Capacity is a clinical evaluation performed by clinicians. Competence, oops, my poll just popped up again. Competence, on the other hand, is a court determination. Competence involves legal decision-making, legal guardianship, legal proceedings, and often occurs when there's a dispute about decision maker who should serve as a surrogate decision maker. But we have to remember that sometimes competence is sort of a legal evaluation. It's quite universal. It understands the patient's ability to sort of make on a broad level, but capacity is about specific particular decisions. So there are some people who are legally incompetent, but they might still have capacity to make a particular decision about their healthcare. So if you think that you have a case like this, I would absolutely recommend consulting ethics and risk involved. These are really complicated cases, but capacity and competence are not the same thing. So just because someone has been ruled incompetent does not mean they do not have capacity. So if you have any questions, please pop them in the Q&A. We can chat about that right now. We can come back to it later as well. I'll wait to see if anything pops up. Okay, let's go on to our second case. Oh, we've got 2 questions. Let's talk about these. So our first question is, would the guardian have to consent or not? And I think that that's a particularly interesting question in this case. So she's thinking about, asking about a oral contraceptive. Does she have the ability to consent to her own contraceptive, her own reproductive care? I think in this case, if she's demonstrating the ability to understand why she wants a contraceptive and understanding of what the effects of that contraceptive will be, and if having a contraceptive will be consistent with her goals and values, then I think it might actually be okay for her to consent to her own reproductive care. How do you determine what decisions this patient can make and can't make? Great question. It's about understanding the particular decisions that are on the table. This particular question is, she's asking for something like, can I have an oral contraceptive? And so we think through, does she meet the criteria that we've laid out? Does she have understanding? Is she able to understand the medical facts? Does she appreciate, can she integrate the facts within her own goals and values? Is she using reasoning? Is she giving an opportunity for reasoning? And then is she able to express that choice? So that's what I would say for that. Is there anything different around the fact that this is a contraceptive in this scenario? What if it was a different type of medication? I chose, for this case, I think it does make a difference that it's contraceptive. I think that in this case, understanding, protecting somebody, within the competency, there's, what am I trying to say? Capacity, we want to honor patients' decisions, right? We want to be able to honor patients' decisions about making their own decisions about healthcare, their body, right? The right to their bodily autonomy. And because somebody is necessarily ruled incompetent by the courts doesn't mean they don't have the ability to process that decision. So as clinicians, we want to be able to protect the patient in their ability to have that ability to make those decisions. So we have, I think there's an ethical obligation. We have an ethical kind of obligation to honor that patient's ability to make decisions that they can make. So once a guardian has been named, are you still saying healthcare workers need to assess for capacity in every healthcare decision? That's tricky. Potentially, but potentially not. If the patient is, and why I would say, call ethics. If the patient is demonstrating that they have the ability to make decisions, if they meet the criteria for capacity, then we have to think really critically. If this patient has, can we let this patient make decision in light of their competency evaluation by the courts? And I want to say, perhaps make a distinction that legality and ethics is not always the same. Something might be ethical does not mean it's always illegal, or it's illegal, and something that's illegal might not always be unethical. So this is why I think it's important to get risk involved. So perhaps if we had a disagreement between this patient and the guardian, there might be some indication that we should weigh with the patient. In this case, if the patient saying, I want oral contraceptive for this reason, and there's logic behind that reason, and the guardian is saying, no, absolutely not for another reason. And perhaps we might want to think agreeing with the patient would be appropriate in this case. Someone says maybe making a decision about contraception is not as high stakes as making something about a significant treatment like chemotherapy. Absolutely. The stakes of this are it's absolutely right to take the stakes involved, the stakes involved in the patient's life and in their medical care. We can absolutely take that kind of information involved. Okay, so this has been fantastic. I'm going to move on to our next case. Case 2, a 57-year-old man with congestive heart failure is admitted to the hospital for volume overload with increased oxygen demands. It becomes clear during his stay that he has not been taking his medications at home. And while in the hospital, he's refusing diuresis and demanding to leave. His care team is concerned he might die if he leaves. So does this patient have capacity? I will launch our next poll. Probably about 10 more seconds. All right, poll is over, share results. Most people said yes, this patient does have decision-making capacity. A few said no. So I would say answer likely yes. This patient does probably have decision-making capacity. We should not assume that patients who do not have decision-making capacity because they disagree with medical advice or they make a decision against medical advice. Determining capacity is about understanding how a patient really reaches a particular decision, not whether that decision is preferred or recommended by the care team. The two pieces of capacity that are really essential to understanding why patients might go against medical advice are the understanding piece and the appreciation piece. So we should honor refusals when patients can demonstrate that their understanding of the realities of the refusals, if they can understand the realities of those refusals and where that refusal is consistent with their values and goals. So in this case, if the patient is able to explain their choice, why it is consistent with their goals and values, and if they can use reasoning to reach that, this patient has capacity and can leave against medical advice, even if they might die. If this patient's refusal is based off of delusions, we should assess their capacity and consider a surrogate decision maker. Do we have any questions about this specific case, leaving against medical advice and decision-making capacity? Does he have to convince us he understands? I think there is a little bit of convincing that has to happen. So if you, as a clinician, are not convinced that he understands, that's a pretty good indication that there needs to be some more investigation, that he needs to demonstrate his reasoning. If he is not communicating and not willing to express his reasoning, we don't have the ability to actually assess his capacity. Therefore, I mean, call ethics, call risk. There might not be the ability for you as a clinician to say this patient does have the capacity to make this decision. So patients really do need to be able to express that choice and to communicate that they fully understand the decision. Okay. And yes, patients can always walk out on their own. We would have to have really clear reason to hold a patient, right? Really clear indication that a patient might be able to be appropriate for something like an involuntary hold. So that would be the case if a patient just decides to get up and walk out on their own. All right. Let us move on to our next question or our next case. All right. A 20-year-old woman with anorexia nervosa is admitted to the hospital for malnutrition. She refuses a feeding tube. However, the care team determines that she does not have the capacity to make decisions about her food intake due to her eating disorder. They place the feeding tube with her mother acting as her surrogate. Now, preparing for discharge, the patient typically would return home to live with her parents. However, this patient is refusing to discharge home, asked to be placed at a group home instead, stating that she does not want to live with her mother anymore. So true or false, this patient does not have capacity to make decisions about her eating disorder, so she does not have capacity to make decisions about her discharge plan. Poll has started. About 15 seconds to think through this one. All right, I'm going to end the poll soon. Great seeing your responses come in. All right, so most people said this is false. The patient does have capacity or have the ability to make decision about her discharge plan. Some said the statement is true. So let's talk about this. Go ahead, if you have any questions, please put them in the chat. So the answer is indeed false. Just because this patient does not have the ability to make decisions about her eating disorder, it does not mean that she cannot make decisions about her discharge. So a patient who lacks capacity in one decision does not necessarily lack the capacity to make all decisions. So in addition to assessing a patient's capacity about medical decisions, clinicians can assess if patients have capacity to make choices about living independently, handling finances, or participating in research. And that is separate from a patient's ability to make a specific medical decision. And each type of decision, this is because each type of decision requires different skills, and it really calls for an independent assessment of capacity. So in this case, while this patient can't make decisions regarding her food intake and a feeding tube, she likely can make a decision regarding where she wants to live. So just because a patient lacks capacity in one area does not mean she lacks capacity in all areas. As we know, decision-making is a spectrum. Decision-making is not all or nothing. So let's check some questions in the chat. How can the care team determine that she does not have capacity? Are there specific tests or evaluations? That's a great question. There are a couple tools we can use to assess capacity. There's a couple measurements, but the most important thing is through conversation and that criteria that I mentioned before and we'll come back to later. Does the patient understand? Do they appreciate? Do they express a choice? And do they use reasoning to reach that choice? Great. Okay, I'm going to move on to our next case. Fantastic. All right, case 4. A 60-year-old woman with cognitive impairment is found to have uterine cancer and needs a hysterectomy. She lives independently and works for a local grocery store. True or false? Any patient with cognitive impairment does not have the capacity to consent to surgery. So I'm launching the poll now. Love to see these questions coming in or the responses coming in. Fantastic. I'll end the poll in 5 seconds. All right, poll is over. So most people said the statement is false. Some said true, but most people said the statement is false, that any patient with cognitive impairment does not have the capacity to consent to surgery. The answer is indeed false. Decision-making capacity and cognitive ability are related, but they're not the same thing. Decision-making capacity is about a patient's ability to make a specific decision. Cognitive ability encompasses a broad range of abilities. Cognitive tests, therefore, aren't a suitable substitute for capacity assessments. So they don't address the particular nature of a medical decision. They address patients' broad sort of global abilities to make sort of decisions or to be able to use cognitive skills, but they don't necessarily indicate if a patient is able to make a specific decision. So for this particular case, cognitive ability does not uniformly mean that a patient cannot consent to surgery. So clinicians should absolutely do a capacity assessment. Any questions regarding cognitive ability and capacity assessments? So does somebody need to have an evaluation, like a perhaps a cognitive evaluation or a specific sort of mental status evaluation to have the 4 criteria? Or perhaps, okay, I get this question. Sorry, let me read this question again. To this evaluation, is it necessary to have the 4 criteria, understanding, appreciation, reasoning, and expression of a choice, or are just 2 or 3 sufficient? It's actually absolutely important for all 4. To have all 4 would be essential. So if a patient perhaps understands the medical facts and says this, appreciates and understands their goals and values, but their decisions are based off of a delusion, then that is not an indication, or it's an indication that they do not have capacity. If the patient cannot actually express their choice, they do not have capacity. We can't really assess then if they have understanding or appreciation. If the patient understands the medical facts, but can't demonstrate that they integrate into their goals and values, then that's a sign that they perhaps don't have capacity and is an indication that we could perhaps either do more investigation or is perhaps enough to justify that this patient doesn't have the capacity to make this decision. All right, so, and then I see a question from Kaylee who says, who carries out capacity assessments? We will get to this in one of our cases, so I'm going to put a pause on that question. Okay, I'm going to check the chat. Looks like we've got some good updates. Thanks for your chat, and keep the questions coming in through the Q&A. All right, let's move on to our next case. Case 5. A 77-year-old patient wakes up after surgery with altered mental status and is found to lack decision-making capacity. Can the patient regain capacity during this hospitalization? All right, poll has been launched. Looking forward to your results. All right, probably 5 more seconds on our poll. All right, so most people say yes, this patient can regain capacity. Someone said no. Let's talk about it. So the answer is yes. Patients who lack of decision-making capacity is not always permanent. Sometimes it can be very short-lived, especially for patients with evolving medical conditions or mental illnesses. So just as delirium waxes and wanes, decision-making capacity also fluctuates. So in this case, the patient is likely temporarily incapacitated as a result of surgery. And in patients like this, capacity must be regularly reassessed. So if we have a case where a patient's capacity is fluctuating throughout the day, it's appropriate to have those important discussions, such as consent or a capacity assessment, perhaps, when the patient is at their peak capacity, say in the morning, right after they have breakfast or something like that. And it's also appropriate to repeat these conversations at those peak capacity times to ensure that any of those decisions are an authentic reflection of the patient's values and goals. So if the patient agrees to a capacity, agrees to a procedure while they're at their peak capacity, but then by the time the procedure comes around is adamantly opposing it, perhaps in the procedure is taking place at a time where they don't have capacity, we can proceed with least restrictive means. So first we should consider, is it possible to perform the procedure during the patient's peak capacity? If not, or if the situation arises, bring in ethics and risk. It might be appropriate to consider something like sedation and restraint, or something that's called a Ulysses contract, where we work with the patient to agree to a plan to allow the patient to receive the procedure that they agree to during their peak capacity when they are in the moment of their incapacitated state and disagreeing with the procedure. So these things are all actually ways to protect the patient's authentic autonomy when the patient is incapacitated. But this is really complicated and nuanced, so I absolutely recommend getting ethics involved. All right, let's check the questions. All right, so let's go back to one of our cases. In this case, with the gentleman with chronic denial or delusion denial figure into determination of capacity. So if we have someone who is delusional and is clearly stating something like, the hospital is out to get me, or these clinicians are trying to kill me, that's something that indicates to us that this patient is perhaps, we know that to not be true, right? We know that is not necessarily the case. So that indicates to us that this patient is perhaps not able to use reasoning to make a choice. So that's how it would factor into capacity. And that would perhaps indicate to us that we need to consider either looking to a surrogate decision maker, or sometimes just a friend or a family member to help us understand this patient better. So it would absolutely be an indication that we should look forward and look towards gathering more information to make sure that we're helping this patient, acting in the best interest of this patient, and helping this patient make the best choice possible. And then we have another question. Is it possible that a patient's values and goals can change as well? Yes, that's absolutely possible. If a patient is expressing different values, perhaps than they had in a previous hospitalization, or perhaps that they have in, perhaps even in something like a written document, like an advance directive. So say a patient comes in as previously always stated, I don't want any life-saving measures. I want to be DNR. I don't want anything done. Don't do anything. And then perhaps they have a hospitalization and they talk to a clinician and they learn about their current medical facts, and they say, I want everything done. That's something that we can take as perhaps it indicates to us that we need to have further conversation with that patient to truly understand, are their goals and values, have they changed? And have they changed because of new medical information and facts? We want to allow people to have the freedom, right, to change their goals and values. We would never want to hold somebody to a document that they wrote perhaps 10, 12 years ago before they actually had the correct information in front of them in the moment. So we want to be able to honor patients' decisions and goals and values that they have in the moment. And everyone has the right to change their mind. That's a great question. Thanks, Michelle. And then we have another question. When the patient does not have advanced plan or any family friends to help him, can the care team can decide using the family's best interest or the person's best interest ? So what happens when there's no surrogate or no person to look into? We actually have a session all about surrogate decision making. So surrogate decision making is complicated and there can be a lot of nuances, but in general, really briefly, yes, we can go to something called the best interest standard, which will indicate sort of how do we make decisions when no one else is around to help us make a decision about this patient that's in this patient's best interest when they cannot decide for themselves. Absolutely recommend getting ethics involved if this is the case so that we can have a clear process of proceeding. Someone says, ask cognitive ability is not the same as decision-making capacity, but can cognitive testing be helpful and additive? Absolutely. Cognitive testing can absolutely be indicative of perhaps that we need to assess capacity further, or, oh, this person has some cognitive testing and they score quite low on that cognitive testing. So perhaps we can have in our conversations with the patient, we're having conversations, we still should address the patient, right? As a respect for that patient, as a respect for that patient's, that person, that autonomy, that human being within the patient. And then if that, if the cognitive assessment is in fact, manifesting itself in that patient encounter, that's absolutely fine. You're absolutely right. They are connected, but they're not always the same, right? They can't be considered the same. Absolutely connected though. All right, let's move on to our next case. Case 6, a 68-year-old patient arrives at the hospital for a scheduled surgery. However, during the informed consent process, the patient states that they are here for a different surgery than the one scheduled. True or false? Because this patient does not have the adequate information regarding the surgery, it means they lack capacity. All right, here's our poll. Fantastic, wonderful responses coming in. Maybe 5 more seconds for responses to come in, and then we'll share the results. Okay. So most people said the statement is false. Some said the statement is true. So what is the answer? The answer is the statement is false. In large healthcare organizations, we know that patients can receive countless points of information from a variety of sources, and it is not unlikely that these sources might conflict with one another, and a patient might not have all the information that they need to understand treatment options. So while a patient who has not received appropriate information cannot give informed consent, this does not mean that they lack capacity to make an informed decision. So capacity is the potential to make a decision and understand the facts, while informed consent requires that patients have the correct facts. So that's the key difference between something like informed consent and capacity. Capacity is all about potential, and does the patient have the ability to process through and do that understanding, appreciation, reasoning, and expression. Informed consent is the actual kind of, it can be considered an event, right? Or a process of, do you understand that, let's walk through this particular decision, and do you understand the facts? Have you been given the facts to make this decision? All right, let's check the questions. All right, this is a very interesting question. Perhaps goes back to our first a question of competence and capacity, which there are quite a few. So I think we would probably come back to this question at the end of the chat or end of the discussion or presentation as well. But this person asks, how would you suggest dealing with a patient who has capacity and is competent and is demanding care that their medical team views as futile? Tricky. If the care is medically unindicated, there's no indication that this patient should receive this care. So for example, the patient is demanding a particular antibiotic for a viral infection. Clinicians have medical expertise, and that medical expertise is what indicates what options the patient has to choose between. So autonomy allows patients to choose between medically available options, and those options are determined by a clinician. So if a patient is demanding a specific treatment that is not medically indicated, the clinician does not have an obligation to offer that treatment. Now, if we're wading into the very nuanced discussion about code status and resuscitation, that I would say is a very complicated and perhaps a different discussion that deserves its own session. So I'm not going to address that here today. But medical expertise is essential in providing patients an opportunity to choose between, right, the medically appropriate options. And that's how patients exercise their autonomy, is between medically appropriate options. All right. So let's go on to, case 7. So a 44-year-old patient with psychosis needs a diagnostic procedure. Does this patient's psychosis mean they do not have decision-making capacity to assess that procedure? All right, let's go to, sorry, I forgot to stop sharing. Case 7. Interesting, great results coming through. We'll have about 5 more seconds. Okay, I'm going to end the poll, share results. So we have most people saying no, the psychosis does not mean, or the patient's psychosis does not mean they don't have capacity, and some people saying yes. So what is the answer? The answer is, in fact, no, not necessarily. So certain patients with psychiatric disorders, certain psychiatric disorders can still retain capacity. Certain psychiatric disorders do not necessarily mean that patients lack decision-making capacity. So as we know, things like psychosis and schizophrenia, they can present on a spectrum, which means that patients might have the ability to fully understand and make their own medical decisions when they have these disorders. So the presence of these syndromes does not necessarily mean that a patient lacks capacity, but it does indicate that clinicians should be attentive to capacity, probably perform capacity assessment. And finally, patient is on a hold if they're involuntarily committed. We should maybe consider, but if they're not on a hold, then they probably do have capacity, right? They probably do have capacity. So that's a key indication. I'm going to move straight to our next case because it's related. And then we can talk about psychiatric disorders in greater length after this. So case 8, a patient with major depressive disorder with suicidal ideation and a plan is placed under involuntary commitment. The care team is considering 2 different treatment options of equal risk and benefit. Should this patient who's under involuntary commitment participate in the decision-making process? Our poll is now live. Results are coming in. All right, 5 more seconds and I'll close the poll. Okay, so most people said yes, this patient should participate. Some said no. The answer from the ethics perspective is yes, this patient should participate. Even involuntarily committed patients should not presume incapacity with these types of patients. These kinds of patients, involuntary committed patients, they should still participate in decisions as much as they're able to. But I do want to indicate that it's not necessarily legally essential that this patient participate, but it is ethically recommended. So it would, when we think about decision-making capacity and participating in decisions, it's about honoring the patient, honoring the person there and their abilities that they have at the moment. So if there is a way that we can honor that patient's ability to participate in decision-making capacity, we should do it. We should take that chance. We should take that moment to honor the patient. All right, and we'll move on to our final case before we go back into more global discussion about decision-making capacity. So for our final case, a patient with borderline personality disorder is admitted to a critical access hospital. This hospital does not have access to mental health professionals. Does this mean that the care team cannot assess the patient's capacity? And our poll is live. All right, a few more seconds for people to respond. All right, I'm going to end the poll. So most people said no. Some people said yes. So what is the answer? The answer is, in fact, no. All clinicians responsible for the care of the patient have the ability and should be able to perform capacity assessments. And this is because every clinician has an encounter with the patient. Psychiatry and mental health experts can be incredibly helpful, and particularly helpful when mental illness is a key factor in determining a patient's capacity. So in this case, with borderline personality disorder, it would be fantastic if a mental health professional was able to assess, but capacity assessments can be performed without their involvement. So if there is no access to mental health professionals, for example. And in fact, primary clinicians might actually even be better positioned to assess capacity, as these clinicians are interacting with the patient's decision-making process over a longer period of time than a consulting clinician might be. So these primary clinicians might be better positioned to understand that patient as a person and to evaluate if their decision-making process aligns with their goals and values. So that is I'm going to look for any questions about sort of who can carry it. So going back to Kaylee's question, who can carry out a decision-making capacity? Any clinician who encounters and engages with the patient should be able to carry out its decision-making capacity using those criteria. Does this patient understand? Can they appreciate and integrate it into their goals and values? Are they using reasoning, and are they expressing a choice? If at any time a clinician is concerned or feels that there is a flag, if a red flag raises, oh, I think this patient might not actually be using reasoning, for example, raise that with the care team. Consider, should we do a more robust capacity assessment? How can we fully understand this patient's decision-making process and make sure that we're helping them make the best decision that they can? All right, what is ethics' role in assessing capacity? Great question. So if we as ethicists are not involved in, how involved should ethicists be? I would say that as an ethicist, I'm a consulting, member of a team. So I perhaps do not have access to a patient's decision-making process like a clinician does. So in that sense, I might not be able to assess that particular decision, that particular patient's capacity, but like any person who's present on the care team members, if I as an ethicist am noticing that there are concerns about the decision-making process, I can absolutely raise those concerns and take a pause and say, let's assess this capacity. But as an ethicist, clinicians are the ones who assess capacity. So we need to have medical expertise as that person, and nurse, I want to say nursing too, so clinical expertise. So this is not just physicians, nurses, PAs, nurse practitioners, mental health experts, right? People who are part of the care team who have clinical expertise can make those capacity assessments. All right, so I am going to do a sort of myth-busting kind of compilation of the myths of decision-making capacity in the cases that we've just discussed. So as a reminder, competence is not capacity, though they are related. And in the Q&A, I can see a lot of amazing questions that I think deserve a lot more attention. So we can get back into this topic. Going against medical advice does not always mean, it does not equal lacking decision-making capacity. Capacity is not all or nothing. Capacity is a spectrum. Cognitive impairment does not always mean lacking capacity. Capacity can fluctuate through times of day, through weeks, through a hospital stay. Informed consent is not the same as capacity. Patients with certain psychiatric disorders can still retain capacity. Involuntary committed patients should participate in their medical decision-making as much as they're able, and any care team member can assess decision-making capacity. So these are, I think, the main takeaways when it comes to the nuances of decision-making capacity. And of course, we should remember capacity is understanding, appreciation, reasoning, and expression of a choice, right? Those are our criteria for decision-making capacity. So let's get into some discussion. We have about 10 minutes left. There's some fantastic questions in the chat that I want to get to. If you are looking for a recording of this event or want to share this event with your colleagues, go ahead and go to the bioethics.umn.edu website, and it should be under the events tab. If you need a certificate of attendance, please email to Kayleen Nagel at that email above, and there will be an evaluation of this session that pops up. So let's get into some questions. So let's talk some more about the difference between competence and capacity. Competence is a legal evaluation, and it looks at sort of through legal proceedings, a global ability for a patient to retain the rights to make their decisions, to retain sort of bodily autonomy rights. Capacity, and it's a kind of a global assessment. Capacity is, can this particular person make do they have the ability to make a decision about a particular medical event and a particular procedure, particular treatment and intervention. And I think that one of the reasons why we need to consider these things separate is that the ability for a person to sort of make a decision in the moment, as we know, it can fluctuate. Ability to make decisions can fluctuate throughout the day, throughout a season, throughout a hospitalization. So competence is a legal ruling, and it happens once, and it occurs, for a specific period of time. So competence in the legal framework might not actually get at, can this patient actually make this decision? And as clinicians, as care team members, we really need to honor patients' ability in the moment to actually make their decisions. And so there could be ethical justification to allow a patient who might be incompetent to make a decision because they have capacity. And that's why you should absolutely get ethics involved if you think you have a case like this, because a patient might be ruled incompetent by the courts, but after evaluations and assessments, it's clear to the clinician, then we might have ethical justification to allow the patient to make that choice. So that's a fantastic question. Okay. Let's go back to this question about contraception. So this, I think I mentioned this a little bit earlier, but I think when we think about something like patients who lack competence, who are ruled incompetent by the courts, and can they still make decisions about low stakes versus high stakes questions or decisions about their treatment? I think that if a patient does in fact understand and appreciate, and if they can meet these questions for capacity, if they meet the criteria, that even very high stakes life or death decisions, they might be able to make that choice. However, I don't think that we should just move forward and say, okay, they can make a choice, let's move on, check the box. I think that we ought to give the patient an opportunity through a just process as clinicians, through a process that allows them to express, can they, really make this choice? And how can we honor that? How can we honor that as clinicians to be able to respect them as the person that they are? Okay. What happens when the guardian is not in agreement with, say, contraception or medication? If the clinical team, if it's something that's in the best interest of the patient, if a guardian's not in agreement and they're not acting in the best interest of the patient, then there might be an indication that this guardian is not acting inappropriately. And perhaps in our surrogate decision-making discussion in our session, we can address something like this in more detail. Guardians are also held to the best interest standard. If it's something that is not necessarily indicated for the patient doesn't, something like contraception where the patient doesn't necessarily need contraception to flourish in the world, something like that. They don't necessarily need it to have good health. Then we have to think through, is the reasoning that this guardian is using enough to outweigh this patient's interest and their reasoning for this decision, right? So I think that we do have the ability to weigh those two things and to understand if those two different perspectives, which one might actually be the perspective that we should allow to take forth. And that, I think, it's a really complicated question that deserves also a process which allows us to go through a procedures. But if it's something like, so I do want to make a sort of nuanced nuance here, that if a patient is under a Jarvis order, right, that is a court indication that this patient is receiving this medication, and that even if the patient disagrees and offers good reasons, that indication, that court order for that specific medication will take forward and will go through. And that's because it's already been determined that that is a particular medication, particular thing that is in the patient's best interest in this moment. Diane has a great question. What are the real world impact of being deemed incompetent by the legal system? And I don't know, I can't necessarily answer this from a legal perspective. I can answer this from an ethical perspective, that the patient has essentially been removed of their rights, and those rights are then transferred to that guardian. And that can go from, financial rights to their own financial freedom, rights to medical decision making, right, and bodily autonomy, and ability to choose, where they go, things like that. And I think it's a really, really serious thing, right? Like taking and removing those rights from someone requires really high evidence, and as clinicians, I think we have an obligation to the patient, right? We have an obligation to the person before us to really critically examine, does this patient actually have capacity in this moment, even though the courts have deemed them incompetent? All right, I'm going to scroll down to the end of our session. We only have a few more minutes, but I think this is a great question. How does the age of a patient impact capacity, particularly teens? I think that adolescents, right, are an in-between. So children are, we look to their parents to provide assent to procedures. Teenagers, they might demonstrate that they have the capacity to understand, right, to be able to make those decisions, but those decisions need to be made with their guardian. And there might be a case for minors who do not have sort of parental involvement at all, that they might be able to make decisions. It's a really interesting question, but age does in fact impact a person's ability to have, to make a medical decision. They might be able to have capacity, but that doesn't mean that they can make a decision on their own. I think that deserves almost its own entire session. So I'm going to answer that briefly. What a great question. Am I familiar with the ACE tool for capacity evaluation? I'm a little bit familiar with it. I think it's great. I think absolutely use that sort of, if you want to use an assessment tool, that's absolutely a good one and you should use it. Yes. So does intelligence ever come into play? For example, the patient has a 4th grade reading education level. I think that a patient who has something like a reading or education level is absolutely still able to make decisions that relate to their goals and values. So even if a person has only completed, say, or has in fact never been educated, but they're an adult, and they don't have cognitive impairment, that they absolutely have the ability to make decisions that align with their goals and values. That person knows what their goals and values are, and it's up to the clinicians, right, to sort of help that person, at their level of education, understand what are the medical facts in this case. So that is an obligation that clinicians have, to be able to interpret kind of the medical and the clinical scenario. That's a great question. Do I think, as an ethicist, that legislation needs to get closer to these ethical discussions about capacity in a healthcare perspective, or do they need to be distanced because they are about different things? That's a fascinating question. As my personal opinion, I think that legislation can always benefit from ethical expertise. I think that having ethicists and having input from ethicists is always going to benefit the situation. And that as ethicists, we might be able to provide nuance to things that might be glossed over if ethicists were not present. So yeah, if any legislator or wants to seek advice from ethics, there are plenty of ethicists out there who I'm sure would be absolutely happy to offer some advice. All right, we have one more question. Oh, whoops, sorry, I accidentally deleted that person's last question. I'm so sorry, it looked like it was a great question. If you can put it back in the chat, please do. Oh, it's unanswered maybe. So when many procedures can have rare but severe consequences, how do we as clinicians ensure appreciation without inducing undue stress and fear? In my experience, appreciation is the fourth element lacking the most. That's a fantastic question. So if you have a procedure that is, I think the question here, or the key thing here is rare, to be honest. So if there's a procedure that has really severe consequences, but they're rare, I think explaining the rarity both with and without statistics is really important, because as we know, average people, we misunderstand statistics all the time. So if we think that, 2%, if the reality is 2% of the population has this rare thing happen to them, we take that to mean that there's a 2% chance that it will happen, I will have this thing happen to me. But that's not always necessarily, so I'm like, oh, that's really low. But that's not always necessarily how statistics translates, right? Statistics is much more complex than that. So what I would recommend is that being really honest and providing the right information is really important, and being really clear about the likelihood is really important, and trying to allow that person to understand statistics as far as without inducing undue stress and fear. I think it's important to say this could be unlikely. So you have, using phrases that are understandable to everyday people, it's absolutely appropriate to do. And I don't think that puts you in any sort of, potential harm in this case. So we have reached our end of our session. Thank you so much for attending this session. I am going to stick around for maybe 5 more minutes to sort of talk through some questions if possible, but we absolutely appreciate you coming to this session. Thank you so much. And we look forward to attendance at the next future sessions. Keep your eye out for continued information about the future of this series. So I guess I can go back to, I want to finish my sentence as about providing sort of honest yet appropriate feedback when it comes to sort of informed consent process of a procedure. Absolutely tell people what the realities, make sure that they know about severe but rare consequences, but don't put too much emphasis on it that becomes the sole focus, and make sure that patient can sort of, as they're expressing their perspective, do your best to understand, is this patient fixating on this particular rare consequence, and how can I as a clinician address that and sort of make sure that particular consequence is held in equal weight with the realities at face. And ultimately, in the end, if that person does not want to, that rare consequence says absolutely not, I think we ought to respect that. And in the end, but I think that does warrant a long discussion, and should absolutely take your time in discussing with this patient. All right, fantastic. So that's it for today. Thank you so much. Again, if you have further questions, please email and contact us further. And thank you so much for attending, everyone.